Ultrasound, particularly transvaginal ultrasound, is a valuable tool in evaluating the endometrium. It allows visualization of the endometrial thickness, which changes throughout the menstrual cycle and can be a sign of various conditions. Endometrial thickness can help identify abnormal growth or endometrial thickening, which may require further evaluation, such as endometrial biopsy. It can also be used as an initial evaluation for abnormal uterine bleeding. The cause of abnormal uterine bleeding can depend on age, whether premenopausal or postmenopausal. In premenopausal women, the endometrium is expected to be in the proliferative or secretory phase. And half of these patients, they have DUB, meaning there is no intracavitary pathology. There can also be polyp. The most common causes in premenopausal are polyp and fibroid. After menopause, the endometrium is expected to be thin. The common pathology or intracavitary pathology after menopause are polyps and carcinoma. Endometrial thickness is a good test after menopause because in menopause, the endometrium is expected to be very thin. In postmenopausal women, the normal endometrial thickness generally is less than 5 millimeters. In this series, 1 in 5 patients who had not measurable endometrium had cancer. The point is, if the endometrium is not measurable, just report it as not measurable, and it has to be considered as abnormal so that additional tests can be done. When looking into the endometrium, we look at the echogenicity or the uniform endometrial echoes or echogenicity. So first is a 3-layer pattern. If we see a 3-layer pattern in a young woman and in her first half of the cycle with a dominant follicle, this is reassuring. The endometrium can be hypoechogenic or hyperechogenic also if this is seen during the second half of the menstrual cycle with a corpus luteum in the ovaries, then that means it's a post-ovulatory phase, and it can be isoechogenic. Sometimes the endometrium can be non-uniform due to cystic areas, can be homogeneous with regular cystic areas or with irregular cystic areas, as well as heterogeneous background without cystic areas, either regular or irregular cystic areas. After looking at the echogenicity, we have also to check on the midline. The normal endometrium has a somewhat linear midline. Sometimes it can be non-linear, but in these cases, it has to be observed for a few minutes because this can be due to myometrial contraction. If the endometrial midline is somewhat irregular, then it needs to be checked carefully because there can be a hidden lesion. When we see a bright edge, this is the interface between the myometrium and the intracavitary lesion. This is a sign of either a polyp or a fibroid. After looking at the midline, then we have to check for the endometrial-myometrial junction. It is important to check for this, but it is somewhat difficult to see in some cases. It can be described as regular or irregular or interrupted, and in some cases not identified. This is a picture of regular endometrial myometrial junction. If this is somewhat irregular or interrupted, then it can be due to adenomyosis or sometimes some invasive cancer. In young woman who is presenting for infertility workup, it is also important to look for synechia. Synechia are strands of tissue crossing from the anterior to the posterior myometrial wall. This is some like adhesions in the areas of adhesions in the uterine cavity causing infertility. Sometimes we see also intracavitary fluid, especially in postmenopausal women. But the point is, it's not the fluid that matters, but what causes the fluid, what causes the intracavitary fluid. The fluid can be classified as either anechogenic or ground glass, or it can be of mixed echogenicity, which is typical of blood or blood clots. Next to assess is the color score. We assess the color score similar to that of the ovaries. For a color score of 1, which is no color, to from color score of 1 to color score of 4, which is abundant color. When there is abundant color flow, this is somewhat suspicious of malignancy. And with the color pattern, we have to see also the vascular pattern. A single dominant vessel going into this endometrium can be seen, and this is typical of endometrial polyps. When we see multiple vessels with multifocal origin, and again, this is suspicious intracavitary lesion. For the when we see an intraendometrial or intracavitary lesion, we have to characterize or estimate the extent of the endometrial lesion. It is described as localized if the base of the lesion is less than 25% of the endometrial surface, and it is extended if the base of the lesion is more than 25% of the endometrial surface. And also, it's important to classify these lesions either pedunculated or sessile lesion, because in hysteroscopy, sometimes sessile lesions are being missed because of the broad base, and then the scope will go through in the cavity, and then it will miss this sessile lesions. Also, we have to look at the outline, either it is smooth or irregular. For irregular lesions, we have to differentiate it with a blood clot, and the way to do it is by opening the color flow or the Doppler. So if there's a colored flow to the lesion, that means it's not a blood clot. For evaluation of the submucous fibroid, we use the grading of 0, 1, and 2. 0, that means like 100% of the lesion is within the uterine cavity. Grade 2, if more than 50% is protruding into the uterine cavity. And grade 2, if less than 50% is seen in the intrauterine cavity. This is important in assessment prior to doing hysteroscopy, because the grade 0 lesion is somewhat easy to remove, but for grade 2, it might take some time. So how do we go about detecting this endometrial pathology? The one procedure that we do is fluid instillation, either using saline or gel. The procedure is being done with installation of the fluid, and then this fluid will create this anechoic background so that the intracavitary lesion can be visualized clearly. So the instruments needed for this procedure are the speculum, catheter, and either the saline or the gel installation. In this procedure, it's important to avoid introducing air because it will cause a poor visualization of the cavity. So it's important to flush the catheter. First, we have to remove the air from the syringe, connect the catheter, and then flush. And then instill the fluid slowly. And during the installation of the fluid, then try to check on the screen the endometrial cavity and identify either a polyp, a fibroid, or a synike, and do some color flow. So the difference between the saline and the gel fluid installation is that for the saline, it might cause backflow, which is inconvenient. It can also cause cramps and pain because of the high infusion volume, as well as there is the concern about transtubal flow, which some experts says it might seed malignant cells into the pelvic cavity. But according to reports, it's not been associated with any prognostic for any prognosis in malignant cases. So for the gel, it has the advantage that it has little backflow. There is no risk of transtubal flow, and it requires only small volume. We can also check for the prediction of the myometrial and cervical invasion through the transvaginal ultrasound. This is based on the FIGO classification. And as a rule of thumb, when the lesion is somewhat small or hyper echogenic, the invasion is somewhat less likely. When we visualize the endometrial myometrial junction and it appears to be regular, again, this is invasion is less likely. And also when the tumor, when there is a thick tumor-free myometrium, the invasion is also considered to be unlikely. And when we turn on the color Doppler, there is low tumor perfusion, or with a color score of 1 to 2, then the chance of invasion is also unlikely. As when the mass is somewhat hypoechogenic or with mixed echogenicity, these are signs of possible invasion, or for some large tumor, tumor with irregular and non-visible, not visible junctional zone, and when there is a thin tumor-free myometrium, as well as also like a high tumor blood supply or color score of 3 to 4. Then in these cases, invasion is more likely. So in summary, for the subjective assessment of myometrial cervical invasion, if the tumor is small, somewhat hyperechogenic, with the large tumor-free myometrium and the regular endometrial myometrial junction with low tumor perfusion, then invasion is unlikely. And then in cases where the tumor is somewhat large, with either hypoechogenic or mixed echogenicity, with a small tumor-free myometrium and the irregular or not visible endometrial myometrial junction with high tumor perfusion, then this is suggestive of invasion. Yeah, thank you.